Hi, this is Minnis Joannides, Chief Medical Director at Optimum Re, and this is the Optimum Academy on Cholesterol 101, video number 3, Underwriting Lipoprotein Levels. So let's get started. So lipoproteins, the good, the bad, and the ugly. The good lipoprotein is HDL, which is wrapped by apo big A. That's the good cholesterol. The bad cholesterol is LDL, wrapped by apo big B. That's in the middle in the blue circle. And then at the bottom is the ugly, lipoprotein little a in parentheses. And that's an LDL molecule with these beads attached on the side, which is in the red circle. And that's apo little a, which is attached to the apo-B on an LDL molecule. So that makes up lipoprotein little a. So when we get an exam 1 or CRL lab profile, what do we get? In the red box, I have cholesterol, HDL level, and you'll notice that the LDL level is actually calculated. Then we get the total cholesterol over HDL ratio, and we use the triglycerides at the bottom as well, right? So this is the typical lab profile that you would see regarding lipids, including the cholesterol, etc. So we're going to talk a little bit more about lipoprotein little a, or LP little a, and there's actually an awareness day to make people more aware of this particular molecule that's genetically determined. So some people have it and some people don't. And the reason to be aware of this is we need to identify people that are at risk due to elevated levels of lipoprotein little a. And people, young people that may have an adverse family history of coronary artery disease might have a calcium score done and it's 0, which is usually very favorable. But if they happen to have a high or elevated lipoprotein little a level, they may still be at risk. Many life companies are ignoring lipoprotein little a in their underwriting risk analysis of a case, and that's not advisable. Everyone should be aware now that elevated levels of lipoprotein little a put applicants at risk. And it's still not well understood, and ChatGPT or Perplexity or whatever generative AI tool you may use may give you the wrong answer because it actually gets confused about lipoprotein little a or apo little a versus apo big A, which is on HDL, the good cholesterol. So you have to be careful when you research an answer that it's actually giving you the right information. So when we talk about lipoprotein little a, we have to know which measure of units we're using. So are we using milligrams per deciliter or nanomoles per liter? So it depends on which measurement we're using, and you can see what high levels are and normal levels. So be aware of the units of measure when you're looking at lipoprotein little a levels. Now here's a case I saw. It was a very large case. It was from a foreign country, and all the cholesterol and lipid levels were absolutely normal except for one thing. And you'll notice in yellow, there's a tiny little arrow pointing up. That's because the lipoprotein little a level on this particular person was elevated way above the normal level, which is 0 to 75. And this was in the 200s. So this person was at risk, but the underwriting by the direct company completely missed the lipoprotein little a elevation and did not rate this appropriately. Here's another large case I saw. And if you look at the top, the typical lipid report that we get shows cholesterol, the total cholesterol, the LDL calculation, HDL, cholesterol ratio, and triglyceride levels. So everything looks great at the top. However, reports that we're seeing now in APSs contain reports about apolipoproteins now. And you'll notice that in the middle portion, where it says ApoB and it's circled in red is 120. That's an elevated ApoB level, and ApoB we know wraps around the LDL molecule. So in this case, although it looks ostensibly normal, if we look at our typical cholesterol levels, HDL and LDL, and the cholesterol HDL ratio, and the triglycerides, the ApoB level is actually elevated. So this is an abnormal finding. And then at the bottom, you'll notice that the lipoprotein a, or LP a in parentheses, is also elevated at 57. So those two things put this person at risk, even though the typical things we look at in an APS or the typical things we see on a exam 1 or CRL lab profile look completely normal. So there's things going on that we should be aware of, which in the past we may have overlooked or not paid any attention to. So the way I look at it is, it's kind of like an iceberg. At the top of the iceberg are the typical things we've used in the past to recognize abnormal lipids, like HDL, total cholesterol, and the total cholesterol HDL ratio. But there's a lot of things under the surface that we should be paying attention to adequately assess the risk on people that might have elevated lipoprotein a or ApoB levels that are elevated. So again, here's a typical exam 1 lab profile, and I've highlighted that the LDL is actually a calculated number. And doctors that monitor patients, they look at LDL and they give them target values, especially if they've had a prior cardiac event. So the way that the lab currently measures LDL, this is exam 1 now, is they use what's called the Friederwald formula, and it's LDL equals total cholesterol minus HDL minus triglycerides divided by 5. And that's a formula that's been used for years, decades actually. And I calculated it out and I got 41. The lab actually reported it as 40. That's okay, we're close enough. And that's a picture of Dr. Friederwald. He worked for the NIH when he designed this formula to try to give us an idea of what the LDL calculation should be. And he eventually left the NIH and worked at MetLife as the chief medical director at MetLife. And I worked with him when I was at MetLife. So he was actually in the insurance biz for a while. Now, one thing we know about calculating the LDL using Dr. Friederwald's formula is that if the triglycerides are elevated over 400, that follows up the whole works. So the LDL calculation is invalid when the triglycerides are over 400. So that's a problem. And if you were trying to design a way for a doctor to have a target range for a patient, if the LDL is invalid like this because the triglycerides are elevated, that would be a problem, right? One thing that people are moving to now is what's called non-HDL cholesterol. That is total cholesterol minus HDL. So it's taking all the cholesterol minus the good cholesterol, HDL, and we call it non-HDL cholesterol. And this is something that, exam 1 is part of Quest. Quest actually reports this in their labs, but exam 1 hasn't adopted it yet. But it's something I've asked them to add, and I put it at the bottom in red. So start looking for non-HDL cholesterol to try to get your arms around what that level actually is, and that's the total cholesterol minus the HDL. And it takes away that calculation that you have to do for LDL. So it's a lot more durable and easier to use. And here's a Quest lab that was in an APS that I saw, and you see at the top, it says LDL cholesterol highlighted in yellow at 155. And then if you look at the paragraph that I put in the red box, this is on Quest now, not exam 1. We said exam 1 uses the Friederwald formula. Quest, which is actually the mothership for exam 1, they actually started using something called the Martin-Hopkins calculation. And that's slightly different than the Friederwald formula. So now Quest, which has like 28 different labs and is huge in the United States, uses the Martin-Hopkins calculation, and it's because Martin was the investigator and he worked at Johns Hopkins, so that's why it's Martin-Hopkins. And it's supposed to be a better calculation for LDL cholesterol than the Friederwald formula. And then you'll also notice toward the bottom, they actually have non-HDL cholesterol reported, which I just mentioned. I've asked exam 1 to start using, and that gives us a number for that. And then at the very bottom, I've put the Friederwald formula tends to underestimate the direct measurement of LDL, especially if the triglycerides are in the higher range, 200 to 399. If it goes over 400, then we said the Friederwald formula doesn't work. But even in the higher ranges of triglycerides, 200 to 399, the Friederwald formula loses its ability to give us a better number on what the LDL actually is. So that's why people have gone to this Martin-Hopkins calculation. So these are target levels for LDL that doctors use in clinical practice. So, you know, if one of their patients has had an event, a cardiac event already, they may tell the patient that you need to take statin drugs or whatever, change your diet in order to improve your outcome. So they'll give them a target to shoot at, like less than 100, less than 70, whatever the case may be. However, we're starting to see these advanced panels in APSs, and this is an advanced Quest panel. And you'll see at the top are the typical cholesterol measures that we're using now. And then they also included non-HDL cholesterol. All those in that lipid profile look to be normal, right? And then in the middle, they have this thing called particle size, which is something we should start paying attention to. And you'll notice that a lot of the particle size values are in the non-optimal range. Then at the bottom, we have apoprotein B and lipoprotein little a levels, and both of those came out in the optimal range. So in this particular case, the typical things we measure looked okay, and the ApoB and lipoprotein little a were okay, but the particle size situation was in the non-optimal range. Here's an advanced cardio IQ lipid panel, and it shows you again, at the top, we have total cholesterol, and we have a normal total cholesterol HDL ratio. So probably in many companies, this would not be rated or considered that abnormal since things look pretty good. But if you look in the red box, something's amiss here. And what we notice is that at the bottom, where it says lipoprotein little a in parentheses, which is being measured in nanomoles per liter, that level is very high. So in this case, this person is at high risk due to the elevated lipoprotein little a level. Now here's an article just to show you how far behind I was in my understanding of cholesterol. This was actually written 20 years ago in November of 2005, and it says non-high density lipoprotein cholesterol and apoprotein B in the prediction of coronary heart disease in men. And the conclusion of this article was, although non-HDL cholesterol and ApoB were both strong predictors of CHD in this male cohort or group, more so than LDL, the findings support the concept that the plasma concentration of atherogenic or bad lipoprotein particles measured by ApoB is more predictive in the development of coronary heart disease than cholesterol carried by these particles measured by non-HDL cholesterol. So what does this mean? What it says is ApoB was the best predictor. And that's what wraps around an LDL molecule. But we can actually measure ApoB now with a lab test. And that gives us a good idea of what the risk is. That's a better measure than non-HDL cholesterol, which we can measure as total cholesterol minus HDL, which is better than measuring or calculating LDL. So if you had to choose what's the best way to assess risk, it would be number one is ApoB, a lab test giving you that number. Number two is non-HDL cholesterol. And then the worst of the three was LDL. Even though doctors still use LDL as their target range, it just shows you that these other two factors may be better in terms of predicting coronary heart disease in men. So again, keeping an eye on what are the most important factors to look at. When looked at a meta-analysis, that means an analysis of a lot of other studies when put together, it was concluded that over a 10-year period, a non-HDL cholesterol strategy would prevent 300,000 more events than an LDL strategy, whereas looking at ApoB levels would prevent 500,000 more events than a non-HDL cholesterol. So again, the best of the bunch to predict risk is the ApoB level, then non-HDL cholesterol, and then trailing the group is the LDL level, even though we still use it for target ranges. And you can see at the bottom I have an ApoB level highlighted on this blood test, and it was elevated or non-optimal on this particular test. So keep an eye out for these expanded profiles when you look at APSs. I used to be afraid of what the results were because I didn't understand them, but the more you get into it, the more understanding you have and the better your risk selection can be, depending on what the person's levels of these lipoproteins are. So what's called lipid discordance is, as we said, the LDL level is not as good a predictor as ApoB. So if you have your choice, go with the ApoB if you have that number to give you an idea of the risk. And we call it discordance because the ApoB level may be elevated even though the calculated LDL level is not that high. So if you had to choose which was the better predictor, the ApoB level is a better predictor of risk. So keep an eye out for these Cardio IQ advanced lipid panels and look at not only the typical things that we used to look at, but look at these new factors and keep an eye on this particle size and particle numbers, which we will be learning more about in the future that can help us in assessing risk of somebody's blood profile. Here's something I put together as an unofficial lipid risk factor. So I looked at thousands of select insurance applicants' cholesterol lab data from one of the labs, and I came up with my own calculation. And this is something you can just use as a curiosity, but what I called the risk factor was I took non-HDL cholesterol, which is total cholesterol minus HDL. I divided by HDL. I multiplied by an amplifier, 11, and then I subtracted from that calculation a novel factor of 23 to come up with my unofficial lipid risk factor for cholesterol. You can try it and see if it adds any advantage to you when you're looking at an applicant for selection and assessing their lipid risk. So that completes video number 3. Stay tuned for additional videos on Cholesterol 101. We'll see you then.